Welcome to JADEL TV. This is a video that I posted on Twitter that got 50 plus likes, and I promised I would bring over to JADEL TV to discuss further. As you can see from the title, it was a straightforward example of a patient who presented with acute dyspnea, a mild elevated troponin after prolonged immobility. This patient was confirmed to have a pulmonary embolism. It was rather large and bilateral, and the echocardiogram showed a really nice example of a McConnell's sign. There was a lot of discussion on this case. Pretty much everybody agreed that it was a McConnell's sign, and there was some discussion about the possibility of whether this could have represented an RV infarct. So I wanted to go over some of the imaging features and then show you one paper I thought was pretty important that specifically looked at this differential. So if we just take a look here in this case, this is again subcostal view. You can see the LV, the RV, and the RV free wall, which in this case is akinetic. As you get down to the RV apex, which is normally very thin and minimally contractile in normal patients, in this particular example, it appears to be hypercontractile, and that's actually the feature of the McConnell's sign, is the if you will, sparing of the apex, but in actuality it almost looks like it's more hypercontractile, and there's been a fair amount of discussion as to what's the etiology of this. But the classic feature is this hinge point right here where the apical portion contracts vigorously and the free wall portion is akinetic. And again, I'll let that play. So here you can see again sort of that hinge point with normal motion at the apex and then akinetic free wall. Now, somebody raised the question about whether this was an RV infarct. And if I just go back and take a look at the interventricular septum, they were concerned that this was akinetic. I think you can see here in diastole that the septum does appear a little bit hypokinetic. I don't think you can see evidence that it's truly akinetic. And sometimes your eye wants to focus on the middle of the LV and the inferior septum here. If it looks like it's not contracting towards the middle part of the septum, it's read as akinetic. But if you watch for just sheer thickening of the septum, so not necessarily motion, but wall thickening, you're able to see that it does actually thicken in systole. From diastole to systole, there's a significant amount of wall thickening. And so that tells you that it's not akinetic. So one feature would be to help try to decide is obviously the clinical setting, which in this case fit better with a pulmonary emboli. The electrocardiogram is often helpful in the setting of an acute inferior STEMI. I like to look at the short axis view, which was not shown, but in the short axis view you can often see the inferior septum, and the adjacent part of the RV in the short axis view is directly attached to the area of the LV that's not moving, and the RV similarly doesn't move in that area. I'm going to alert you to a really important study that was published in back in the days when we used to call the European Journal of Echocardiography in 2005, published by Franco Casazza, C-A-S-A-Z-Z-A. It was in volume 6, page 11 to 14. And in that study, they nicely compared patients presenting with a acute pulmonary emboli and a RV infarction. And they had a fair number of patients in each group. And they went on to explain in their discussion, basically what they found was you could not tell reliably between the two. And you really had to look at these other features, that the wall motion itself was not a good, reliable way to separate acute RV infarction from acute pulmonary emboli. That McConnell's sign could be seen in both. The three mechanisms that they used to try to explain the etiology of a McConnell's sign was tethering of the RV apex when you have a hypercontractile LV, as you do in this case. And I think that's actually a really good explanation, but the authors believe that that's not a good explanation. In my experience, when you have an acute pulmonary emboli, you underfill the LV. If the LV is normal, it does become hypercontractile, and therefore it does pull on the normally thin portion of the RV apex, which is directly adjacent to the LV apex, and therefore it helps tether it. And when you have acute pressure overload and hypokinesia of the free wall, probably due to ischemia, you end up with what appears to be hypercontracting tethering of that apical motion. So like I said, that was one of the three explanations. The other two were that there's mid free wall elevated afterload from the pressure overload of the pulmonary vascular resistance from the acute pulmonary emboli. And the third was actual RV segment ischemia, where the RV free wall is ischemic. So what the authors concluded is that the RV apical motion is a real inward movement, not just tethering. So they actually thought that that was not an etiology. RV infarction does not result in sudden increase in afterload, is what they said. And yet they still saw the McConnell's sign in 2/3 of their patients. I'm not so sure that you don't have patients with acute RV infarction that can have a elevated sudden increase in afterload, but that was what the authors proposed. And therefore they weighed their opinions that the third most likely explanation for the McConnell's sign actually represents RV free wall ischemia. And that transient ischemia from the acute infarction or a more prolonged ischemia with possible necrosis in RV infarction were the two mechanisms most likely driving their finding, and the fact that it was seen in both clinical populations. Anyway, I hope you enjoyed this discussion, and I'll talk to you soon next week when we have more cases brought over to JADEL TV. Thank you.